Okay, I'm doing that right away. We are live on Facebook as well.
Thank you
Dr.
so much.
Aisha. Okay.
So good evening, ladies and gentlemen. I am Dr. Aisha Bianca Edwards Remy. I'm the head of clinical services at AR Hospital. Thank you for taking time to join us this evening. We do apologize. We are starting roughly 9 minutes late. Today, we are joined by Dr. Bakri Onyambu. Dr. Onyambu is an obstetrician gynecologist with a subspecialty in laparoscopic surgery. He is a graduate of the University of Nairobi for both his undergraduate and postgraduate degree. He has worked in most, if not all, of the major hospitals in Nairobi. He currently works at AR Hospital and runs a clinic on a Wednesday and a Friday. Dr. Onyambu will be taking us through uterine fibroids, its presentation, its management, and maybe how we can move forward as we start our fertility series. Good evening, Daktari. Karibuni sana.
Thank you, Aisha, for the warm introduction and the kind words that you mentioned about me. It's really a pleasure for me to be with you this evening just to discuss this very important and common condition, the uterine fibroids. Thank you. Thank you. I'm just going to go straight into the discussion of fibroids, and I want to begin with really what fibroids are. And it's a common condition we hear mentioned everywhere, but what are really fibroids and how would we define them? Fibroids are a condition of the uterus or the womb, if you'd want to call it that way. And they're a condition of particular part of the womb as the muscle of the womb, the smooth muscle of the womb. And it's also fibrous connective tissue that's around these smooth muscle cells. They develop in the uterus and appear alone or as commonly is seen in groups. And they vary in size from very tiny little ones as small as a grain of rice to as big as a melon. In some cases, fibroids really can stalk into the uterine cavity or grow outwards of the uterus. In the next slide, I'm just going to show you, just to help you have a grasp of the anatomy of the reproductive system in the woman. And at the center of it is what you see there demarcated as the womb or the uterus. The uterus is made of two parts. Right at the top, you will see is the top part that is named the fundus, and the lower part of the uterus that connects to the vagina is called the cervix. And that part of the uterus, or rather the whole uterus, is composed of an inner lining, which sheds off monthly as periods, the endometrium. And then you have a strong muscular part of the womb, which is really where the fibroids grow. And the other parts of the reproductive system, just to mention in completion, is at the top of the womb, as you see there, connected is the fallopian tube. On the left-hand side of your screen, you will see a schematic diagram of that, and it's got different parts of it, which I don't think you'd want to memorize at this stage. And on the right-hand side, you've shown you what it would look like in real life, really, the position of the fallopian tubes and the ovary and that part of the uterus called the cervix, etc. So the fibroids develop or do grow in the muscle of the womb, that part that is called the myometrium that you see there. In this slide, again, I show you this gory picture that tries to depict very many possible locations of uterine fibroids. They can be located almost anywhere on the womb. There are those fibroids that grow right in the center of the muscle of the womb. And those fibroids do not come towards the surface of the outside of the womb or towards the inside of the womb. Those are what we call intramural fibroids. Indeed, these are the most common type of fibroids, the ones that are growing right bang in the middle of the muscle of the womb. And they can grow really, really large, and they sometimes can really stretch the womb to almost a full-term pregnant size. And these intramural fibroids, there are those fibroids that grow towards the outer surface of the womb. And that is not the surface that is not facing the inside part where the baby would ordinarily sit. Those ones that grow towards the outer surface of the womb, we call them the subserosal, because the outer surface of the womb is called the serosa. Anything that covers any organ is called the serosa. So that those that are growing toward the outer part of the womb, they are called subserosal fibroids. Most of these subserosal fibroids can grow very big, and they do not tend to cause any symptoms except just for the sheer growth in size and those symptoms that will be caused by the pressure that they cause, unlike the fibroids that grow towards the inside of the womb. Sometimes these subserosal fibroids can grow and only remain attached by a very little stalk to the womb, like the one you see depicted at the top of that picture. Now we call these ones pedunculated fibroids. In fact, when they grow very big in this position, one can sometimes feel them wobbling like a growth or a hard mass in the abdomen, wobbling from one place to another. And patients can actually hold it and say that I have a swelling that I can move from one side of the abdomen to the other. These are what we call the pedunculated fibroids. Again, these ones, besides the trouble they cause of just, a sensation of something moving inside the abdomen, really don't cause any other major symptoms. Then we have the category of fibroids that do grow inwards towards the cavity of the womb. And these can be in various positions. For example, the one that you see depicted in that picture there, like a ball right bang in the center of the womb. That one is almost completely extruded into the cavity of the womb. It remains attached by a very tiny little stalk to the inside cavity of the womb. This one, again, there are different types or names that we are given to them, because these are the ones that cause most of the symptoms that are attributed to fibroids. These ones that are growing into the cavity of the womb. Like that one that is bang in the center, we call it a type 0 submucous fibroid. All of them are called submucosal fibroid. Any fibroid that is going to be touching the inner surface of the womb, what we call the endometrium, or distorting it in any manner, is called a submucous fibroid. And this one that is bang in the center is called a type 0. And then there is a type 1 and a type 2 submucous fibroids. Again, the symptoms they cause vary in severity from type 0 to type 2 fibroids. So these are the different types of fibroids. You have intramural fibroids, you have subserosal fibroids, you have pedunculated fibroids, and you have submucous fibroids. So what really causes fibroids? The truth be told is really no one knows. No one knows the origin and cause of fibroids. There are some postulations regarding what causes fibroids. Some people have demonstrated that the genes that are contained in the cells that are in fibroids tend to differ from those that are in the typical uterine muscles. So some people have demonstrated that this could possibly be a cause. The change in the genetic makeup of the muscle cells may result in the expression of the proteins in that cells in a different manner. and making the cells grow rapidly and of a different consistency. And these result in fibroids. So there is possible genetic change that results in fibroids. And we know, secondly, that the two hormones that are produced majorly by the ovary, that is estrogen and progesterone, tend to stimulate the uterine lining during each menstrual cycle. We also know that these two hormones also stimulate the growth of fibroids. Fibroids have been shown to have more estrogen and progesterone sensitivity expressed by the receptors, or the kind of things on the surface of the cells of fibroids that receive estrogen and progesterone more than the ordinary uterine muscle cells. So some people think that the origin of fibroids may actually be hormonal, or hormonal makeup may contribute to the formation of fibroids. There are other substances that the body produces, or hormones that the body produces for its own growth and development. For instance, growth hormone or growth factor, others called insulin-like growth factor. All these people have postulated may be contributing to the formation of fibroids. Fibroids are not just composed of the muscle cells. We also know that the cement around the cells, cells like building blocks you can imagine in a building, also have the cement around it. And it has also been shown that the cement-like material around cells that makes the cells stick together is increased in the tissue that is composed of fibroids. So this extracellular matrix, as we call it, may also contribute to fibroids because it makes the fibroids very fibrous. So these are the various postulations that towards what we think may be causing fibroids. We also know that fibroids do occur more in the nulliparous, or those who have not had children in the past. And we also know that people who have more children tend to have fewer chances of getting fibroids. So there are all these factors that may be contributing as possible causes of uterine fibroids. So how common are they? How common are uterine? Let me just say on the onset that uterine fibroids are very common. They affect, especially in the African population, close to 80% of women. If you just assessed women in their reproductive age group, more than 80% of them will have uterine fibroids. Again, it occurs in a little less frequency in the Caucasian population, where only about 70% of them do have fibroids. But again, not all women who do have fibroids will exhibit symptoms. Not all of them. The majority of them will not have symptoms. 70% of all women who do have fibroids will not have any symptoms at all. It's only 30% who will manifest with some form of symptom, with some in whom the fibroids will affect them in one way or another. And how do fibroids affect one's lifestyle or one's life? One, fibroids may cause abnormal uterine bleeding. Again, as I did illustrate in the previous slide where I showed you the various locations, fibroids that are located closer to the inner lining of the uterus will distort that inner lining and will result in heavier bleeding during periods, or sometimes bleeding in between periods. So you can have very heavy periods lasting the same duration, but very heavy, or one can have bleeding in between the periods when one is waiting for the next period and they're spotting. And this is what we call abnormal uterine bleeding. This is mainly caused by fibroids that distort, one, the inner lining of the uterus, and by sheer increase in the bulk and size of the uterus. Again, this may contribute to abnormal uterine bleeding. This in turn may lead to a lowered hemoglobin level. The blood level, because of constant loss, may be low, and this is what we call anemia. So one may present with symptoms of anemia per se, not even knowing that they have fibroids. They may feel weak rather. They may feel dizzy. They may find themselves having, awareness of heartbeat when they try to exert themselves. And many times, as I've seen with younger people, they may not even recognize that they are having periods, but may just come to the clinic with the feeling of anemia. Commonly, the single presentation of fibroids to the clinic is just symptoms of anemia and anemia itself. If the fibroids are large and they're big, they may cause pressure, and this pressure may be to the adjacent structures, and somebody may feel pelvic pressure, a sensation of pressure in the pelvis. Sometimes they may even cause pain, particularly when they undergo changes. There are sometimes occasions where fibroids can grow very big, but even if they're not growing so big, they may grow rapidly, and as it were, they outgrow their own blood supply, and they become deprived of blood and oxygen. When this happens, it tends to cause changes within the fibroid matter itself, and this causes pelvic pain. And this may be just the presentation somebody comes with to the clinic, that I have pain in the lower abdomen, I have a sensation of pressure. This pain may be sometimes very of sudden onset, acute sudden onset pain, but most of the time it is a chronic type of pain. If fibroids are big, and particularly those that extend towards the backside, tend to cause back pain. So this is a presentation of fibroids also, that they may cause back pain. Because just in front of the uterus in normal anatomy is the urinary bladder. Sometimes when fibroids are big, they may, of course, interfere with the expansion of the bladder when it's filling with urine. So one may get a sensation of filling of the bladder more frequently than ordinary, and this is what we call urinary frequency. And again, likewise, because fibroids may grow big and extend backwards, and behind the uterus is the rectum, where the stool is stored before it's finally passed out. And again, because big fibroids may interfere with the free propulsion of the contents of the intestines down to the rectum, they may cause constipation and difficulty in emptying the rectum, or difficulty in passing stool. And even sometimes, because of this, they may cause blood flow around the rectum and the anus to be interfered with, causing swellings around the anus, what we call hemorrhoids. So they may interfere with the normal function of the large intestine, particularly the section of the large intestine called the rectum. Fibroids again may cause difficulty in conception or inability to conceive, largely depending on where they are located, particularly those fibroids that are located towards the inner lining of the uterus. Those ones can lead to difficulty in conception or inability to conceive. Again, what about fibroids and pregnancy? How do fibroids affect pregnancy, and how does pregnancy affect fibroids? It's a two-way question. One, fibroids may interfere, again, let me say this at the onset, that most of the time, fibroids can coexist with pregnancy until delivery without any problem at all. But very occasionally, you may find fibroids interfere, one, with the position of the baby. Because if one imagines that they are large fibroids and they are growing towards the lower part of the uterus where the baby's head is to be, again, if they're in that position, they may cause the head not to position itself down, and the head may be up, and the lower part may be occupied by a large fibroid, therefore malpositioning the baby, making it inconvenient, or rather unable to have a normal delivery because of poor position. Because of this, we know that fibroids are associated sometimes with poor pregnancy outcomes. One may have to have an operation instead of a normal delivery, etc. And how does a pregnancy affect fibroids? Let me just touch on this quickly. because of the hormones that we alluded to earlier on, estrogen and progesterone, which are produced in very large quantities during pregnancy. Sometimes pregnancy may affect the consistency of the fibroid. The fibroid may grow rapidly bigger and sometimes may become very painful because of that change during pregnancy, what we call degenerative changes of fibroids in pregnancy. Again, this can be excruciating, sometimes necessitating even surgery to get rid of the or rather admission into the hospital to get rid of the pain or to treat the pain. So these are some of the symptoms that one may present with. Let me correct that. You cannot have surgery during pregnancy with fibroids. That can be disastrous, but may need to be admitted into the hospital to control the pain, because the pain can be very excruciating. So let's go to the next slide, please. So how can one confirm that they do or do not have fibroids? The general way we confirm a diagnosis or for confirm a condition in medicine is, one, to listen carefully to what problem somebody presents with. Therefore, listening carefully to the history that is given to us is very important. When one comes to the doctor, to the gynecologist, they need to, as clearly as possible, define the problem as they see it. If possible, come with a record of the periods, clearly indicate when they start, when they end, and the quantity, try and quantify the amount of bleeding one is getting with the periods. If there is any bleeding in between the periods, for example, that must be clear. So a very clear history is helpful in helping the doctor try and figure out whether one has fibroids or not. Also any other complaints, as we have alluded to, difficulty in conception, anything that is related to pain, etc., must be characterized very well to help in arriving at the diagnosis. On examination, the most common finding is during the abdominal examination and also the pelvic examination. And in the abdominal examination, if the fibroids are very big, if they are big enough to grow out of the pelvis, that is to grow above the pubic symphysis, one may be able to feel the fibroids themselves above the pubic symphysis. Sometimes it's very obvious, and on very many occasions we have encountered women who appear to even be pregnant, but indeed it's just fibroids that are producing these pregnancies that are never being delivered and being congratulated in the office, yet they have problems, even in conceiving itself. And these growths can sometimes turn out to be fibroids. So a careful history and examination will reveal an enlarged uterus, particularly those fibroids that are not so big and tend not to enlarge the uterus above the pubic symphysis can only be felt by a pelvic examination. This is when your doctor is going to put, of course, his fingers through the vagina and one finger above the pubic symphysis and feel the uterus between the palm of his hand that is placed above the pubic symphysis and the fingers that are placed in the vagina. That can clearly delineate, especially in people who are slim, the size of the uterus and the consistency of the uterus, as well as the regularity or the smoothness of the surface of the uterus. In that examination, one can very easily suspect, in fact, almost confirm that there are uterine fibroids within that womb, as they feel it that way. In terms of imaging, in terms of looking into the pelvis using the technology we have, the commonest imaging technique we have for diagnosing fibroids is the ultrasound scan. The ultrasound scan. Again, this is done with a full bladder. When the bladder is full, as you see in that diagram there, you see the bladder is right in front of the uterus in that person lying down. When the bladder fills up, then it pushes the uterus upwards towards the head. And that makes the visualization of the bladder easier when it is pushed out of the pelvis towards the head by a full bladder. That's why most commonly one would be asked to feel the bladder as they go for the ultrasound scan. The second thing is that the bladder is full. You know that ultrasound, like all sound waves, would travel better through the fluid that is of the bladder and give you a clearer view of the uterus behind. So when one goes to have an ultrasound scan, especially looking at the uterus, then they will need a full bladder. They will need a bladder that is filled up. Then there is a special ultrasound scan that one can do to delineate fibroids that are growing inwards into the cavity of the uterus. They may be small and can easily be missed out by an ultrasound done through the abdominal wall. So one may do a vaginal ultrasound scan using a special transvaginal probe. That is a probe that is pushed through gently through the vagina and lies very close to the uterus and is able to visualize the uterus more clearly. And one may be able to pick smaller fibroids, especially the ones that are growing to the inner cavity, easily using the transvaginal probe. To make it even easier, occasionally fluid is filled into the uterine cavity, the inside of the uterus. And as I said earlier on, it's easier to see any object through fluid using an ultrasound scan. And when you fill the inner cavity of the uterus with fluid, and then you take the transvaginal probe and take an ultrasound scan, if there are small fibroids within the cavity, they would more easily be visualized. And this is what we call a hysterosonogram. And maybe occasionally that may be necessary if one is not able to see fibroids either using an abdominal scan or a transvaginal scan. Another technique that has been used, especially also for those who are looking for babies who have infertility, is what we call the hysterosalpingogram. Hystero depicting the uterus, salpingo depicting the tubes, and gram meaning just a picture. So in this particular test, what is done is using a syringe-like structure, a dye is pushed through the cervix, and this dye goes through the uterine cavity, and then it goes into the fallopian tubes. And serial pictures are taken as the dye flows through all that space. And using this picture, one can be able to see whether there are defects or what we call filling defects within the uterine cavity. And this may be indicative of uterine fibroids. This also helps to show whether the fallopian tubes are open or they are blocked at any one point. So a hysterosalpingogram, often abbreviated as HSG, is one of the techniques that is used when one is visualizing the uterine cavity and may pick out fibroids during that procedure. Finally, sometimes if one still suspects fibroids and has done these imaging techniques and they're not able to see any fibroids, actual visualization of the inner cavity of the uterus can be done using a tiny little telescope that is inserted through the cervix into the uterine cavity. And this can be done even in an office setting without anesthesia. And this telescope is connected to a camera, and the camera is, of course, connected to a viewer, and you can view on something like a screen the inner cavity of the uterus, and one is able to pick out submucous fibroids using this technique. May I add that this technique can also be used to resect or to remove fibroids that may be within the inside of the uterine cavity. Let's go to the next one. I think here I wanted to talk about the treatment of uterine fibroids. Treatment of uterine fibroids. Let's go to the next slide. I think I think that slide didn't capture it all nicely. Let me try and There is a text on that slide that is. Let me begin by the general principles of treatment of the uterine fibroids as that slide loads. One, you can classify the treatment of uterine fibroids into two. One, you can say you can have medical treatment of uterine fibroids, or you can have surgical treatment of uterine fibroids. In terms of medical treatment of uterine fibroids, most of the treatment of uterine fibroids in terms of medical treatment is geared towards shrinking the fibroid. One wants to deprive the fibroid of what makes it grow so that it can shrink and become smaller. And this is done by reducing, as you can well now imagine, the supply of the hormones estrogen and progesterone. That can be done directly either by antagonizing or blocking the estrogen and progesterone from the point at which it is acting, and that is at the fibroid point. And there's some medications that have been used in the past for this in this regard, like tamoxifen, but there are others that actually block the production of these two hormones, estrogen and progesterone, by the ovary. And these are what we call GnRH analogs. So these ones do block the production of this hormone by the ovaries, estrogen and progesterone. Most of the medical treatment for fibroids is based on that principle. So whatever array of medicines that you will get, it's based on that basic principle of depriving the fibroids of the hormones that cause it to grow. That is estrogen and progesterone. So this is one way of managing fibroids. It must be noted here that this does not take the fibroid away. It may shrink into very small sizes. It may prevent the ones that were smaller from growing bigger, but it does not take the fibroid away. And very often, because you cannot continue with these medications ad infinitum or forever, when you stop the medical treatment, the fibroids will start regenerating again. Secondly, one may try to use a surgical technique to remove the fibroids. And when it comes to surgery regarding fibroids, there are different techniques that have been tried. One is the open technique. That is where one opens up the abdomen and does open up the uterus and one by one remove the fibroids safely. And there are various techniques now that have been developed to reduce the bleeding during the process of removal of fibroids that worked pretty well. Long time ago when we did the open technique, the blood loss was very often a lot and we had to transfuse patients. And as far as I remember now, I can't recall when we last transfused a patient when we were removing fibroids using an open technique because of the safety of the various mechanisms that have been developed to reduce the bleeding during removal of fibroids. A second and now increasingly popular technique of operating on the uterus to remove fibroids is minimal access surgery, or what we call laparoscopic myomectomy. The removal of fibroids is generally called myomectomy. So one may use laparoscopy as a technique of removing fibroids in a safe way. Again, there are limitations to this minimal access. The advantages of laparoscopic removal of fibroids is that the incisions are pretty small and they cause less pain. And the recovery, of course, is much faster in terms of resumption to work. But what is done on the uterus itself remains the same. The technique is cutting open the uterus and removing the fibroids, and by various techniques, removing the fibroid from the body without having to make a huge cut on the abdominal wall. This is an increasingly popular technique, but as I said earlier, has its limitations. One, sometimes when there are very very many fibroids, when there are multiple fibroids, it is possible not to remove all the fibroids, because removal of fibroids largely depends, when you do the open technique, the feeling, the tactile feeling using your fingers that you have on the uterus helps one to locate the fibroids and to remove them. This is limited when one does not have access to touch the uterus during surgery and only has to touch the uterus using probes or instruments that are put in. Again, there are very many ingenious innovations that people have tried to circumvent this inability to feel the uterus during surgery, including developing or having a small ultrasound scans put through the spots or the areas that have been made to reach the uterus. But this is a limitation. Granted, this is a limitation that when one has many fibroids, a laparoscopic surgery may not enable one to remove all the fibroids or as many fibroids as one would if they are doing an open myomectomy. The second limitation, again, of this procedure is with very large fibroids, one may not be able to comfortably place the telescope and the instruments and still have enough space to operate while using this technique. So sometimes when the fibroids are very big or very large, there is not enough room to manipulate the instruments that would be placed in the abdomen to operate laparoscopically. So that's another limitation again. The other technique, surgical technique that can be used to remove fibroids, particularly those that are growing inwards into the cavity of the uterus, is a technique we call hysteroscopy. I'd alluded to it earlier on, where the camera is inserted through the cervix and you visualize the inner cavity of the uterus. Hysteroscopy is possible, and there are some fibroids that can completely be removed or resected using hysteroscopy. Again, when they are deeply embedded, it may be dangerous to attempt to use hysteroscopy to remove fibroids, or hysteroscopy alone to remove deeply embedded and large uterine fibroids. So there is again a limitation to hysteroscopy in terms of what number of fibroids one can remove using this technique. Then there are other techniques that are being developed now, or have developed, and now increasingly common, and that is, one of them is uterine fibroid embolization. And this is a technique where the main blood vessels that are supplying the fibroid can be blocked by some substance that is deposited in the blood vessel. This deprivation of blood to the fibroid causes the fibroid to shrink. Again, they can shrink permanently, and this can be done without having to do a major operation or major surgery. So uterine fibroid embolization is possible and can block the blood vessels that are supplied the fibroid and shrink them. Even if the fibroids are pretty large, this is still possible and can be done. There are newer techniques that are being developed now of targeted beams. These are like laser beams towards where the fibroids are, without even necessarily having to operate. And these are experimental techniques that are proven in some areas to even melt down fibroids without having to do surgery. But in our setup here, where we are in Nairobi, we do not have that available. So these are the several techniques that can be used in management or treatment of fibroids. But let me say this in closing, that not all fibroids have to be removed. We do not need to remove all fibroids. If the fibroids are not causing any problem or any symptoms, sometimes we just treat them by watchful waiting. You just observe and monitor. The patient maybe every 6 months or every 1 year, make an appointment and see how they are growing. One would be worried with fibroids that are not causing any symptom, but are very rapidly growing. Those would be of concern. And that's why it's important that when one has been diagnosed to have uterine fibroids, even if they are not causing any symptoms, it is important to go for at least 6 months to 1 year follow-ups just to see how they are progressing. Rapidly growing fibroids are of concern. Rarely, and I say extremely rarely, fibroids can turn cancerous. And those that do so tend to grow very, very rapidly. And that is why it is important to follow up somebody who has uterine fibroids. I think that makes it for my presentation this evening. I would welcome any questions when the time for questions and answer comes, but I hand you back over to Aisha. Thank you.
Thank you very much, Dr. Harry. So there are quite a few questions that we received via email and even in the Q&A section and the chat. I would like to encourage our participants, if you have any questions, it is not too late. Feel free to put it in the chat or the Q&A. So I'll start with Patricia. Patricia, on your side, do you have any questions from Facebook as we are live on Facebook?
Okay, I have two questions. The first question is, once fibroids are removed, can they regenerate again? And the second question, I think the doctor has just mentioned, but probably maybe they missed out. Can fibroids turn into cancer? Thank you.
Thank you, Patricia. I'm Dr. Nyambo.
Thank you. I think I've answered both questions in my conversation, but I'll repeat. Yes, fibroids can come back, can regenerate, even if you remove fibroids. And my experience is that when they are multiple, when you have more than 2 fibroids, they tend to regenerate faster. And if you have, sometimes I've removed even up to more than 20 fibroids. And I always caution that there is a likelihood that they would grow back again. And this may be because they are small, tiny little seedlings that one was not able to remove or to fill during the surgery. Or it may be the fact that people who have multiple fibroids tend to have them growing faster. So, but when there's only one solitary, and occasionally I encounter patients with 1 or 2 solitary large fibroids, those tend to regenerate much slower. If you remove them, and I have done so with patients, and they have lived their entire reproductive life without them coming back again. But the straightforward answer is yes, it's possible that fibroids can regenerate. And again, I said it is extremely unlikely, but it is possible that fibroids can turn malignant. And that is why it is important to monitor fibroids and to monitor their growth, particularly those that are growing very fast. Even if they're not causing symptoms, if they're growing very rapidly, one needs to have them removed. Thank you.
Thank you, Dr. Harry. So I'm going to go through 6 questions that were shared via email, and then I'll go to the questions online. So we'll just take them one at a time. The first one says, if one has a recommendation for surgery, but you have also been informed that you can buy some time before going for surgery, what are the implications of delaying the surgery, say for about 1 or 2 years? I have had only 2 incidences in 2021 of heavy flow, that is in January and in December. In December, the cycle was slightly over 14 days, but heavy, and in January, it was heavy with clots. So I think this person is saying that they may have been recommended for surgery and they want to delay a bit. What is the implication of that delay?
Okay, I think I'll take that one. First of all, let me say that if fibroids are not causing any symptoms, there is no hurry in removing them if they're not causing any symptoms. But if they're causing any of the symptoms that I alluded to, for example, if one thinks that fibroids are responsible for difficulty in conception, they are delaying conception. If you have submucous fibroids that are acting like a coil, you know, that's how we prevent pregnancies, by putting a coil in the womb. Now you can imagine if you have a growth within the womb, it is acting like an IUCD, intrauterine contraceptive device, right there, and is preventing pregnancy. Delaying it would just mean that you're delaying your ability to conceive. But if fibroids are just causing mild symptoms and there is very minimal bleeding and no disturbance in your periods, then one can wait for one reason or another and watchfully wait as they make a decision on whether they would want to have the surgery or not. But if fibroids, again, for instance, are causing heavy bleeding, resulting in anemia, hemoglobin constantly below 10, that significantly affects one's quality of life and endangers them. And delaying would only increase the complications. The burden on your heart trying to meet the blood supply will be heavy. So it may be important to have them addressed sooner than later. But if the symptoms they are causing are minimal and they do not result in a significant disturbance of your quality of life, one can delay the removal of fibroids.
Dr. The next question is, what are the risks involved during the surgery for fibroids, and how can a patient prepare for the surgery?
This is an excellent question. Thank you very much. Risks of surgery for fibroids. There are, of course, and I'm not going to mention those attendant risks to any surgery because there are anesthetic risks, etc., etc. Let me be very specific to the risks that pertain to fibroids. Any surgery for fibroids can result in bleeding. The uterus is heavily vascularized. It's got a lot of blood supplied to it. And bleeding is one of the complications one may encounter during removal of fibroids. And as I said earlier on, there are many techniques that have been used to prevent this bleeding. In my own experience and practice, I have not in the last 5 or more years transfused a patient during removal of fibroids. And thankfully, because of these newer techniques that we use now to prevent bleeding. But that is a risk. Secondly, you can have, especially when you are doing minimal access or laparoscopic surgery, there are attendant risks to laparoscopy that can happen during removal of fibroids, and that is injury to adjacent structures around the uterus. Usually you have the intestines around there, and we use energy, we use electricity, if you want to put it that way, or some sort of energy to cut through the uterus to remove the fibroids. And this energy, if not handled diligently, or sometimes even when handled with utmost diligence, you can find that it can spread and injure adjacent structures, particularly the bowel. We also have the ovary, we have the fallopian tubes around there. Removal of fibroids could affect these structures in one way or another. On a longer term basis, during the healing process after removal of fibroids, one may heal with adhesions. Adhesions are cobweb-like bands that develop between various organs in the pelvis or in the abdomen during the healing process. This can happen however careful one is. And these cobweb-like bands occasionally may become very thick, and they may affect function of the other structures that are around the pelvis. For example, the ovary may be covered with these adhesions or bands and may affect ovulation. The fallopian tube may be covered with these bands or adhesions and may affect the function of the fallopian tube. This is a rare thing, and if done carefully and with diligence and observing the usual precautions in surgery, one can minimize the occurrence of bands, but not completely eliminate adhesion formation or this band formation during surgery. So this is some of the complications that can happen. And there are many other complications that can happen during surgery, but these are the main ones that pertain to removal of uterine fibroids.
Thanks, Dr. Next question, is there a relationship between fibroids and hypertension or high blood pressure? 75% of patients with fibroids have hypertension.
Well, let me answer it this way. As far as I have read, and first of all, let me say that I agree with that observation. I do agree entirely with that observation that that some patients who have fibroids tend to have hypertension, and vice versa, especially when it's a woman who has hypertension, you may find fibroids. As far as I've read, there is no causative relation or causal relation, let me put it that way, that hypertension doesn't cause fibroids and fibroids do not cause hypertension, as far as I am aware. But this is an observation that I've made, and I can only speculate. And again, this is dangerous to say on a forum like this, but it has been mentioned that a certain lifestyle will lead to development of fibroids. And I think that the same lifestyle would probably lead to development of hypertension. As far as the genes are concerned, whether the genes that predispose one to hypertension or to fibroids are the same, I am not aware at all. But my postulation is that it may be a lifestyle thing that may be contributing to both factors, but I agree with that observation, and it's correct that in many times you find fibroids coexisting with hypertension in the same patient. Thank you.
That's our next question. What happens when one discovers that they have fibroids late and uterine prolapse has occurred? Can one conceive in such a case?
Yes, I think that's a good question also. Fibroids do not necessarily lead to uterine prolapse. And again, uterine prolapse can occur without fibroids. That can happen. As far as conception is concerned, there are very many other factors that may contribute to ability or inability to conceive in a patient who has uterine prolapse. There are many techniques that can be used to correct uterine prolapse alongside removal of the fibroids that still support the ability for one to conceive. There are surgical procedures that have been clearly defined that preserve fertility in a woman who desires so when she has uterine prolapse. Yes, that can happen. And if they later would want to conceive and they have prolapse and they have fibroids, my advice would be to remove the fibroids and go through the procedure for correcting the uterine prolapse, and they can go ahead and conceive if there are no other factors that prevent them from conceiving.
How long does it take a patient to recover from surgery after removal of fibroids? And this participant has gone a bit further. They said, for example, if it's 1 month, can an organization give sick leave for the month? And if you require, let's say, an extra time, can the doctor, upon assessment, extend that sick off for more than 1 month, or whatever period the sick off is for?
Duration for recovery after surgery for fibroids. Again, let me answer it this way. It depends on the approach that was used to remove the fibroids. If it is an open technique, then I generally tell people that for full recovery, for the structure of the uterus to completely heal and appear as though nothing has been done to it, you would require at least 3 months for the uterus to heal, even for the stitches that have been used to repair that uterus to completely be absorbed and the scar to completely regain its integrity. One would require up to 3 months. But that doesn't mean that you remain dysfunctional or unfunctional for 3 months. I think within 3 weeks of open myomectomy, of surgery, one should be able to resume their normal activities without hindrance, barring lifting heavy objects, which may put pressure on the incision, the abdominal incision that was made to access the uterus. So 3 weeks, in my opinion, 3 to 4 weeks is adequate for one to resume their normal activity, their normal day-to-day activity. But for one to even consider a pregnancy, 4 to 6 months is what is required, because that scar tissue to regain its integrity, its strength, would require a minimum of 3 months. So I generally advise patients, if you're considering a pregnancy after an open myomectomy, again, depending on the location of the fibroids, one would require at least 4 to 6 months before they can consider getting pregnant. If one has had a removal of fibroids or myomectomy using a laparoscopic technique, the recovery, a resumption of normal activity is much faster. The recovery on the womb itself may take longer, but because they do not have a large abdominal incision, then they can be able to resume their normal routine activity even within 10 to 14 days. They can go back to their normal work. In fact, the pain after laparoscopic surgery is so much lower compared to open surgery that we often need to remind patients after laparoscopy that they have gone through major surgery and that they need to take it slow for a while before they resume work. I don't know whether I answered completely that question. I feel like there was a second part to it that I've not responded to.
So the second part was about, let's say, whatever time, let's say it's 3 weeks. What if that patient is not fully healed after assessment? Can the doctor extend the sick off?
Yes, absolutely. I agree that one can extend the sick off. Again, we all differ. Our pain thresholds differ. Our healing capacities differ. So this is just a general statement I've made, but one has to visit their doctor and review their doctor in the process of recovery or during recovery for the doctor to ascertain that they are okay and fit enough to resume their work. So some it may even be shorter than 3 weeks. For some it may be longer than 3 weeks. So again, personally, I feel like if somebody approaches me and they feel like they're not fully recovered enough for them to resume work, I liberally allow them sick off until they are fully recovered. I think this is good practice. Your life comes first before anything else.
Doc, so this question is a 2-in-1. So first, what is defined as a big fibroid? And secondly, can there be uninterrupted pregnancy even with big fibroids?
I think, let me answer this one in a roundabout way. As with many things, so it is with fibroids, size doesn't matter. I think one can have a tiny fibroid, but is wreaking havoc. For instance, if one has a tiny little fibroid, maybe 0.5 centimeter big, but is growing inside the uterine cavity, it can cause so much more bleeding than a 15 centimeter fibroid that is pedunculated and growing outside the womb. So a big fibroid, for me, that does not matter in as far as symptoms are concerned, but in as far as the technique, and again, this is a technical thing, in as far as the technique of removing the fibroid is concerned, it may be significant. For example, if one has a fibroid that is growing inside the womb, inside the inner lining of the womb, and it is larger than 3 centimeters, I would not attempt to remove that fibroid using hysteroscopy, hysteroscopic resection. That is using the telescope that is inserted through the cervix and slicing off the fibroid bit by bit. There are complications that accrue because of the time, the duration it would take to chip off that fibroid to completion using hysteroscope. Because of that, the size does matter to the surgeon, to the operating doctor, but it may not be relevant so much to the patient in terms of the symptoms it causes. So if you're asking this question pertaining to a recommendation of a certain procedure made to you by the doctor, then yes, size does matter. And if it is a submucous fibroid and it's bigger than 3 centimeters, I would not attempt to remove it using a hysteroscopic technique. But in terms of symptoms as a patient, then the size doesn't really matter. In terms of pregnancy, again, with fibroids, because of the same reason that I've given, location of the fibroid, the position of the fibroid will determine its effect on pregnancy. And again, size here doesn't come into play so much. A pregnancy can exist. I've had a woman with fibroids almost a term pregnancy fibroids. The abdomen was, when she came to the office with fibroids, she looked like she was pregnant at 9 months. But before I could go ahead and do the surgery to remove the fibroid, she came back and she was pregnant. What to do? I had to soldier on with the pregnancy, and she went to 9 months with that pregnancy. And we delivered her, difficult delivery though, but again, left the fibroids there to remove them at a later date. So again, fibroids and pregnancy and size is really varied depending upon the location of those fibroids. I don't know whether I answered that question, Dr. Aisha.
I think you did. So we have another question here. It says, can you get a prophylactic hysterectomy after desired number of children when you have a strong family history of fibroids?
Oh, that's a good question. And I had a patient with that kind of request today. It's such a coincidence that even before I leave the office, somebody is asking the same question. And my answer is no, I don't think so. Probably by the time you finish having your children, you have a few years of menstruation ahead of you, that fibroids will probably not be causing you much symptoms after that. Prophylactic hysterectomy, I don't think is indicated for somebody who has a family history of fibroids, especially if they do not have any fibroids at all. And even if they do have fibroids and the fibroids are not causing them any symptoms, I wouldn't advise them to go for hysterectomy. And here is my reason. I think we sometimes take it for granted that surgeries go smooth. Surgeries can have complications. And when the complications occur, they can affect the quality of life significantly. That actually makes one have a high threshold for recommending a surgery for any patient, even if it's a simple excision of a growth on the skin. Any procedure that is surgical may be complicated by one thing or another, either whether it was anticipated or unanticipated. So one must have a high threshold for recommending any surgical procedure. More so where there is no indication, where there is no reason to have a surgical procedure. I wouldn't go ahead and recommend a hysterectomy because your sister or my mother or somebody related to you had fibroids. No. And even if there are fibroids, there must be symptoms for the benefit to outweigh the risk. Thank you, Aisha.
Thank you so much, Doc. So this question has come up, I think, 3 times. So I'll just try and pull it together. Multiple people are asking, is there medicine or a technology that shrinks fibroid? 1, is it available in Kenya? 2, and if so, which do you recommend?
Okay, I think I had responded to this a little earlier on, but let me repeat. Yes, there is medication. Medical treatment for fibroids is there, but it also has its limitations. As one of the questioners correctly said, the effect of medication for treatment of fibroids is to shrink them, not to make them disappear. It is to shrink them. The fibroids do shrink and they can reduce significantly in size. And the aim of shrinking fibroids may be, 1, to reduce the symptoms they're causing. If they're big fibroids and they're putting pressure on adjacent organs, by shrinking them using medication, you may reduce the symptoms they're causing. Number 2, as a doctor, I may want to shrink fibroids if I am not able to operate on that patient immediately. For instance, if a patient has fibroids and she's bleeding heavily and her hemoglobin is below 10, it would be a risk to take her to theater to try and remove fibroids with a hemoglobin below 10. Therefore, I may want to postpone the surgery, at the same time stop the bleeding so that the hemoglobin can come up, then plan for the surgery at a later date. This is the primary use of medical treatment for fibroids in most cases, is to stop or postpone the surgery as you stop the symptoms it's causing. Reason being, once the medication is stopped, the fibroids will start growing again and cause the same symptoms. So you have a window where you have shrunk them and you want to do the surgery quickly before they grow again and then start causing the symptoms one more time. But some people may just want medical treatment, and sometimes they do give it for patients who are 45 years above, who want to just shrink the fibroids. They don't want to go for the surgery, and they pray and hope that menopause will catch up with them soon. The medication we use for shrinking the fibroids mimics menopause. It's a temporary menopause or a reversible menopause. So sometimes we can give this medication for somebody who's really approaching the menopause to shrink the fibroids, to buy time, and sometimes menopause sets in and they do have no need for surgery again, because after menopause, then the fibroids do not grow any big, and many times they do not cause the symptoms that they cause before, or rather during the reproductive age group. So as for which medications I would recommend and which one is the best, I think I don't want to comment on that in this forum. Let me just say that there are many available in the market, but they do more or less the same thing. The effect of those medications is this, that they reduce the production of progesterone and estrogen and allow the fibroid to be deprived of those two hormones and become smaller during that period. And yes, these medications are available in this country. Thank you.
Thank you very much, Dr. Harry. Before we wind up, and before I do my thank yous, I'd like to invite Mrs. Naomi Wambugu, our head of nursing, to just tell us about our mom and baby fair, which is being displayed on our screen. Naomi?
Thank you, Dr. Aisha. Good evening, everyone. Dr. Onyambo, thank you so much for your excellent presentation. Yeah, so as Dr. Aisha has mentioned, I would like to invite you all this coming Saturday on 2nd of April, 2022. That is the day after tomorrow. We have the event that you see on the e-flyer, Mom and Baby Fair. This is the second event that will be happening in the hospital after we started one last year. It will be inviting expectant mothers and mothers with young babies together with their partners. They will have an opportunity to interact with our consultants in obs-gyn specialty and also in pediatrics. And basically, actually, this includes both visiting and in-house consultants. They'll also have opportunity to interact with other professionals, such as the nutritionist, clinical counselors, and other teams, including the midwives, in various discussions and information sharing. As Dr. Onyambo has done the presentation today, you'll probably find one or two mothers inquiring about opportunity to ask a question about reproductive health. We will not turn away anyone. It will also be an opportunity that any mother with a question about their reproductive health issues can be clarified and they can be followed up in our specialist clinics. The event will run from 9 a.m. to 12 noon in the day. And this is basically to allow our busy doctors to go back to their busy schedules. I want to mention that these services will be free for all. At the end of the day, we shall walk all these participants up to Furaha Ward, labor and delivery suites. Now, by the way, for those who have not been recently in the hospital, I'm glad to mention that at the beginning of this month, we were able to separate Furaha Ward, the medical surgical patients, and now they are being housed at Tumaini Ward, and therefore Furaha Ward remains exclusive for maternity and labor and delivery. We thank you for your patronage and continued support, and we thank you for entrusting us with your patients. Thank you.
Thank you very much, Naomi. So as we continue this fertility series, it's every Thursday at 7 p.m. We want to thank everyone for joining us today. I would especially like to thank Dr. Onyambo for taking time to take us through the management of fibroids. I know that there are still a lot of questions in the Q&A that we've not gotten to today. However, we have exceeded our time of 1 hour. If you are interested in finding out what are the other webinars that we have upcoming or just activities that the hospital is participating in, please feel free to follow us on all social media platforms. You can find us on Facebook, Instagram, LinkedIn, Twitter. So we welcome you to join us, follow us and see what's coming next. Good evening, everyone. Thank you again for joining us. Thank you, Dr. Onyambo.
Thank you, Aisha.
Most welcome, Dr. Harry.